So, welcome to the Kanski lecture series, and this is the vascular disease part 9. And in this part, we are going to discuss about the retinopathy of prematurity. Introduction: the retinopathy of prematurity (ROP) affects premature low birth weight infants. So, it is affect basically the low birth weight infants, usually less than 1500 grams. Systemic illness is an additional risk factor, for example, anemia, sepsis, and low vitamin E levels. The exact cause of ROP is unclear, but early exposure to high ambient oxygen concentration appears to be a key risk factor. With new method of monitoring oxygen levels in premature babies, oxygen use as a major risk factor for has diminished in importance. So basically, what happens is when the premature birth babies are exposed to the high concentration of oxygen, so it will first decrease the proliferation of the retina, and after when there is a hypoxia ensues, there will be the angiogenesis of the retina. So that is how the retinopathy of prematurity occurs. And there are some other risk factors like anemia, sepsis, and low vitamin E levels. In an early phase of ROP development, vessel growth is retarded by hyperoxia. So, early phase, the growth is retarded by hyperoxia, means the increased supply of oxygen, but subsequently retinal hypoxia promote anomalous vascularization. The retina has no blood vessels until the fourth month of gestation, when vascular complexes grow from optic disc hyaloid vessels toward the periphery. So, usually the retina has no blood vessels around the fourth month of gestations, mean that when the baby is fetus and it is in the fourth month of development. So basically the vascular complexes grow from optic vesicle hyaloid vessels towards the periphery. The nasal retina is normally fully vascularized after 8 months of gestation, the temporal periphery at or 1 month after delivery. So the nasal retina is already developed before birth, but the temporal retina is uh, basically developed after 1 month after delivery. So that is why hypoxia and hyperoxia have effect on this side. Vascular endothelial growth factor VEGF is believed to play an important role in vascularization process. In developing countries, there has been rise in the incidence of ROP in recent years, which corresponds to the establishment of intensive neonatal treatment regimes in premature babies who would not previously have survived. Tip: babies born before 32 weeks of gestation age or weighing less than 1500 grams should be screened for retinopathy of prematurity. Then there is an active disease, and then there is a chronic disease. When there is an active disease, so basically the clinical findings in ROP are described below to the 2005 international classification of the retinopathy of prematurity ICROP location. So there are different zones, zone 1, 2 and 3. Concentric zones centered around the optic disc are described. So then there is a zone 1, zone 2, zone 3. So zone 1 is basically, that here is a disc and here is a fovea. So the distance between the fovea and the disc, you double it, and that is the and you put the diameter around it, so that is the distance of the zone 1. So zone 1 is bounded by an imaginary circle. So this is an imaginary circle, the radius of which is twice the distance from disc to the center of the macula. So radius is basically this is a diameter, but radius is basically half of the diameter. So this is an optic disc and about the fovea, so you double it, and so this is the radius. So the radius of which is twice the distance from the disc to the center of the macula. With a 28 diopter binocular indirect lens, only zone 1 is seen if any part of the optic nerve head is visible. Then there is a zone 2. Zone 2 is basically extending around the disc from the edge of the zone 1 with the radius that extends from the center of the disc to the nasal ora serrata. So basically you start from the oral serrata and then you put a diameter around it. So basically that is the part of the zone 2, and the remaining temporal part is known as zone 3. Zone 3 consists of a residual temporal crescent anterior to zone 2. Then there is a staging. How do you stage the um, retinopathy of prematurity? This describes the abnormal vascular response at the junction of the immature avascular peripheral and vascularized posterior retina. So basically what happened is that there is a vascularized posterior retina and abnormal response an immature avascular peripheral retina, and the abnormal proliferation that occur at that point. Staging of for the eye as a whole is determined by the most severe manifestation. So there are 5 stages: is 1, 2, 3, 4, 5. So 1 is a demarcation line, stage 2 is a ridge, stage 3 is a fibrovascular proliferation, stage 4 is a, partial retinal detachment, and stage 5 is a total retinal detachment. So stage 1 is a demarcation line, which is a thin, flat, tortuosity, gray-white line um, running roughly parallel with the ora serrata. It is more prominent in the temporal periphery. There is an abnormal branching or arcading of vessel leading up to the line. So what is happening? Basically, demarcation line is just a line which is about thin, flat, and grayish white in color, and it is running parallel to the ora serrata. And basically there is abnormal branching or arcading of the vessel which is leading up to the line. Ridge arises in the region of the demarcation line, has height and width, and extend above the plane of the retina. So basically demarcation line has a ridge which basically extend above the plane of the retina. Blood vessels enter the ridge, and small isolated neovascular tuft may be seen posterior to it. Stage 3 extraretinal fibrovascular proliferation extend from the ridge into the vitreous. So when the extravascular fibrovascular proliferation extend from into the vitreous, it is continuous with the posterior aspect of the ridge, causing a rect appearance as the proliferation become more extensive. The stage 3 can be divided into mild, moderate, and severe depending on the extent of the extraretinal fibrosis tissue infiltrating into vitreous. The highest incidence of this stage is around the post-conceptual age of 35 weeks. So basically, post-conceptual age of 35 weeks, it is occurring in that stage. Partial retinal detachment is divided into extrafoveal stage 4A and foveal, which is stage 4B. The detachment is generally concave and circumferentially oriented. So it is a concave because fibrovascular proliferation often leads to tractional retinal detachment. In progressive cases, the fibrous tissue continues to contract, and the detachment increases in height and extend anteriorly and posteriorly. Stage 5 refers to a total retinal detachment. Then there is a plus disease. Plus disease signifies a tendency to the progression and is characterized by dilatation and tortuosity of blood vessel involving at least 2/4 of the posterior fundus. Other features include failure of the pupil to dilate and vitreous haze. So in the plus criteria, there are 3 things that you should remember. Number 1 is vitreous haze. Number 2 is failure of the pupil to dilate, and second is the dilatation and the tortuosity of the vessel in at least 2 quadrants. Pre-plus disease is also described. Aggressive posterior rush disease is uncommon, but it is if untreated usually progress to stage 5 sometimes within a few days. It is characterized by its posterior location, prominence of plus disease, and ill-defined nature of retinopathy. So in aggressive posterior rush disease, there are also 3 criteria. It is an like posterior location, prominence of the plus disease, and ill-defined nature of the retinopathy. Then type. So treatment depend on the type of the retinopathy. Treatment guidelines at most centers have been revised based on an early treatment of retinopathy of prematurity, ETROP clinical trial. The concept of a threshold disease formally taken as the criterion for the treatment has been suspected. The outcome improved by earlier intervention. The outcome after treatment varies depending on the severity of the disease. 30% of high risk zone 1 ROP will have a favorable visual outcome. Type 1 treatment is now recommended within a 72 hours for type 1 disease. So if there is a type 1 disease, then a treatment is recommended within a 72 hours. So what are the type 1 disease? It has 3 parts. So any ROPE stage in zone 1. So zone 1 is usually the posterior location, the most posterior bowel in which the macula is present. So it is very sensitive zone. So any zone which is present in zone 1 when accompanied by the plasticines is known as is needs to be treated with plasticines. And stage 3 to any extent within a zone 1, and basically if the stage 3 is also in the zone 1, then we needs to get treated stage 2 and 3 in zone 2 together with plus disease. So in and also in zone 2, if there is a plus disease and the stage is stage 2 or 3, then we treat it. Not basically we don't treat the demarcation line here. So stage 2 is basically disease required observation. So if there is a stage 1 and 2 in zone 1 without plus disease, if there is a stage 3 ROP within a zone 2 without plus disease, then we can treat it. We observe it. So this is a staging of the retinopathy of prematurity. A is showing us a demarcation line. This is the demarcation line. B is showing a demarcation ridge, which is basically increase in height and width. C is showing us a extravascular fibrovascular proliferation. D is showing stage 4A partial extrafoveal retinal detachment, and E is showing plus disease. So you can see vessel tortuosity. F is showing method of imaging a baby. Next is how do you screen the patient with retinopathy of prematurity. Formal criteria vary, and risk factors and screening criteria developed in one country will not necessarily apply in another country. In principle, babies born at or before the 30 to 32 weeks gestational age or weighing less than 1500 gram or less should be screened for ROP. So basically, if the baby is born 30 to 32 weeks before gestation and it is weighing less than 1500 gram, should be screened for ROP. Severe illness in other premature babies may also prompt screening. This involves the indirect ophthalmoscopy with 28 diopter lens or a 2.2 pan-fundoscopic lens and scleral depression, or a wide field retinal camera with full oversight. So we can use indirect ophthalmoscopy with 28 diopter lens. We can use 2.2 pan-fundoscopic Volk lens and wide field retinal camera. Screening should begin 4 to 7 weeks postnatally when the baby is born. Subsequent review at 1 to 3 week interval depending on the severity of the disease, continuing until the retinal vascularization reaches zone 3. The pupil in a premature infant can be dilated with the 0.5% cyclopentolate and 2.5% phenylephrine. Topical anesthetic is instilled and a neonatal eyelid speculum used. Monitoring should, especially for apnea, is prudent during and after examination. About 10% of the babies screened require treatment. Refractive error, strabismus, and amblyopia are more common in children with ROP, and long-term monitoring is required. Techniques have evolved which allows small babies to be imaged. Treatment. So how do you treat the patient? Basically, laser ablation of the avascular peripheral retina has largely replaced cryotherapy because visual and anatomical outcomes are superior. So you can just ablate the avascular retina, so there is no proliferation of that side. So intravitreal anti-VEGF agents, the B-drop bevacizumab eliminates the angiogenic threat of retinopathy of prematurity. Study results have changed the approach to the treatment of ROP. Bevacizumab can be used for the treatment of ROP, but an optimal regime has yet to be established. Zone 1 disease are more likely to respond than zone 2, allowing retinal development to proceed normally without the destruction. Integral to laser treatment is a potential advantage. So in this part, basically the retina is not being destroyed, so it is very advantage as compared to laser. However, systemic complication and long-term effect in this age group are undetermined. In particular, there is a mounting evidence that disease can result from the cessation of the anti-VEGF treatment. Pars plana vitrectomy for the tractional retinal detachment not involving the macula 4A can be performed successfully with respect to anatomical 90% success and visual outcome. The visual outcome in stage 4B is 60% and stage 5 is 20%. So it decreases depending on the stage. So if you do vitrectomy In 4A, it will have a 90% success rate. If you do 4B, 60%, and if in stage 5, 20%. Is typically disappointing even with successful anatomical reattachment. So next is a cicatricial disease, which is basically when the disease become chronic. So about 25% of the infant with active RRP develop cicatricial complication, which ranges from innocuous to extremely severe. In general, the most advanced or more posterior the proliferative disease at the time of involutional, there was the cicatricial sequelae. Findings range from moderate temporal vitreoretinal fibrosis and a straightening of the vascular arcade with dragging of the macula and disc. So what is happening first is there is a vitreoretinal fibrosis that is being occurring, and there is a straightening of the vascular arcade, dragging optic disc from macula and disc. So we can see 13.52 is showing us a cicatricial retinopathy of prematurity. A is showing straightening of the vascular arcade, so the vascular arcades are getting straightened up. B is showing retinal fibrosis with upper temporal vascular straightening, so vascular straightening in the upper temporal part. C is showing us a dragging of the disc and the macula. D is showing falciform retinal fold, and E is showing retrolental fibrovascular tissue and partial retinal detachment. F is showing us a total retinal detachment. So progressing, so first there is a vitreoretinal fibrosis, there can be straightening of the vascular arcade, there can be progressing to the retrolental fibrovascular tissue that can lead to falciform retinal fold formation and to retinal detachment, sometimes total, and known as retrolental fibroplasia, a term that has been used synonymously with ROP in the past. Secondary angle closure glaucoma may develop due to progressive shallowing of the anterior chamber caused by forward displacement of the iris lens diaphragm and anterior synecdoche formation. So, secondary angle closure can also occur. Lensectomy and anterior vitrectomy may be tried, but the results are generally poor. So, this is a retinopathy of prematurity age, head mounted binocular indirect ophthalmoscopy laser under general anesthesia. B showing appearance immediately following the laser photocoagulation for type 1 disease. Then there is a retinal artery macroaneurysm. So there is a retinal artery and there is a formation of aneurysm which is of the macroscopic appearance. A retinal artery macroaneurysm is a localized dilatation of a retinal arteriole and has predilection for the older hypertensive women. So it occurs in the arterioles and it occurs in a older hypertensive woman. Dyslipidemia may also be associated. They are usually solitary and 90% involve only one eye. So how do you diagnose the case of the retinal artery macroaneurysm? Diagnosis symptoms include insidious impairment of vision due to leakage involving the macula. Sudden visual loss due to hemorrhage is less common. So sudden visual loss can occur, but it is less common. So there is a leakage due to impairment of the macula. Fundus show a saccular arteriolar dilatation is typical, often at the bifurcation or at the atriovenous crossing on a temporal vascular arcade. So mostly occur in the temporal vascular arcade and typically at the bifurcation or atriovenous crossing point. The aneurysm may enlarge to several times the diameter of the vessel. This is associated retinal hemorrhage in 50%. So what happens in a case of a chronic leakage? Persistent retinal edema with exudate formation is common that may affect the central vision. So exudate formation can occur and retinal edema can occur with the macroaneurysm. So hemorrhage can occur at any time. It can occur intra, subretinal, pre-retinal bleeding. So hemorrhage, intra, sub or pre-retinal bleeding, the prognosis for a central vision function in those with submacular hemorrhage is poor. Spontaneous involution of following thrombosis and fibrosis is very common and may precede or follow the development of leakage or hemorrhage. So resolution can also occur. Other complications include epiretinal membrane, choroidal neovascularization. So this is a retinal artery macroaneurysm. A is showing us associated with exudates. So there is a macroaneurysm which is associated with exudates. B is showing us a retrohyaloid hemorrhage. B is showing upper temporal macroaneurysm with pre-retinal retrohyaloid hemorrhage. C is showing sub darker intra-retinal brighter red hemorrhage. DFA early venous phase showing hyperfluorescence of the microaneurysm, which is surrounded by the hypofluorescence due to masking of the blood at the same level lesion as C. So FA will show the uniform filling of the microaneurysm is typically with lately changed. Incomplete filling is due to thrombosis. OCT can demonstrate the lesion itself, but its main use is to document and monitor macular edema and less commonly subhyaloid hemorrhage. Vascular risk factors should be checked, especially BP and serum lipids. So how do you treat a case of a retinal artery macroaneurysm? So observation can be done. Observation is indicated in eyes with a good visual acuity in which the macula is not threatened, and in those with mild retinal hemorrhage without significant edema. In many cases, macroaneurysm is spontaneously involate, particularly following retinal or vitreous hemorrhage. So there is always a chance that the retinal hemorrhage can involate, especially after the vitreous or retinal hemorrhage. Laser treatment can also be done. Laser treatment may be considered if edema or exudate threaten or involve the fovea, particularly if there is a documented visual deterioration. Burns may be applied to the lesion itself, the surrounding area, to reduce the risk of arteriolar occlusion or both. So you can just directly hit the microaneurysm, or you can do the surrounding area, and you can do both as well. Sub-threshold laser may be as effective as standard photocoagulation. It may take several months for edema and exudate to fully absorb. Intravitreal bevacizumab closed 95% of the macroaneurysm in a case series with the resolution of a macular edema. ND-YAG laser hyalodotomy may be considered for a persistent premacular hemorrhage in order to disperse the blood into the vitreous cavity, from where it may be absorbed more quickly. Intravitreal gas injection with the face down positioning may shift subretinal hemorrhage away from the macula. Adjunctive intravitreal recombinant tissue plasminogen activator may also be used. So one can also use the intravitreal gas injection and ask the patient to face down, because the bubble will go and attach to the retina, and it will cause the subretinal hemorrhage to shift away from macula. Vitrectomy may be necessary for a persistent vitreous hemorrhage. So this is a spontaneous involuted retinal artery macroaneurysm. So this treatment is showing thus the treatment of retinal artery macroaneurysm. A is showing hard exudate at the macula due to chronic lesion. B is showing us immediately following laser application, and C is showing a large pre-retinal hemorrhage overlying the macula. D is showing following ND-YAG laser hyalodotomy. You can see the vitreous blood is leaking into the vitreous downward. So that's it for the part 9. See you in the next lecture.